today. So I'm going to introduce Dr. Devin Oller. He's a primary care and addiction medicine physician and served one of the first rural health leadership fellows and chief resident at Massachusetts General Hospital before coming to UK. He's an associate program director for the University of Kentucky Internal Medicine Residency Program and is an investigator for the NIH-funded Healing Community Study. Welcome back, Dr. Oller.
Good to be with you all. I'm going to go ahead and share my screen. I don't have any financial disclosures. Today, we're going to try to address a couple practice gaps. So we know that access to medications for opioid use disorder is limited, and that's in part due to minimal provider and community knowledge about what treatment options are available, including extended release naltrexone. We know that there's a gap in understanding both among providers and patients about the risks involved with extended release naltrexone and its variable efficacy in this population. And we know that there's significant costs associated with the initiation of extended release naltrexone, and those are not always well understood by our health systems. We're going to dive a little bit deeper into extended release naltrexone and the other forms of MOUD, how they differ, how their different efficacy, their mechanism of action. We're going to spend a bunch of time trying to come up with good frameworks for talking to clients about the potential benefits and harms of initiating extended release naltrexone and some key barriers to extended release naltrexone initiation. And my hope is that we're able to utilize this knowledge and impact our communities by providing really targeted, patient-centered information about the use of this medication to folks living with opioid use disorder. So we're going to start with this little question, and you can put in the chat just the number 1 to 10 of how comfortable you feel talking to clients about extended release naltrexone. So, can you walk them through the pros and cons? Can you make sure that they're aware of the risks and they know about the benefits? Seeing a 7, an 8, a 6, 7, 7. Okay. Love it, guys. So a fair amount of comfort talking about extended release naltrexone. And I'm glad we're there, and I think that allows us to dive a little bit deeper into some of the nuances of using this medication. And I hope some of our cases and questions answer questions for you about it. Let me go through a couple of brief reminders and overview slides here before we jump into those questions and cases. So we use the plug analogy when talking about our various forms of medication for opioid use disorder, where methadone or buprenorphine is both activating the opioid receptor, but in a slightly different way, with methadone fully activating that receptor, so plugging right into the socket, and buprenorphine almost like a power strip that partially activates the receptor. And because they're doing that, they treat withdrawal, they treat cravings, and they treat pain directly through activation of the opioid receptor. Whereas naltrexone is like the socket plug. It helps keep things safer, right? In that it's blocking the receptor from anyone activating it as long as that plug is in place. But it doesn't help with withdrawal symptoms. In fact, we need to wait a full 7 to 10 days after opioid use before starting it. And when those plugs fall off, we're at elevated risk for overdose because the individual has lost tolerance to opioids. So again, it's high affinity, which means that it binds really, really tightly to that receptor, but blocks other opioids from getting to that. It doesn't treat withdrawal, and it does not cause withdrawal when stopped, which can be a plus, as we talked about last time for some patients. We have to go through an important checklist before starting naltrexone for clients. One is that they can't be on current opioid analgesics, and that includes medications like tramadol. They can't have physical opioid dependence. They can't actively be in opioid withdrawal because if we give them the naltrexone, they're going to go into worse withdrawal. We have to be pretty cautious when folks have some liver damage, but when there's severe hepatic impairment, so when patients are hospitalized with complications of liver cirrhosis, naltrexone really shouldn't be used in those folks. If naloxone or oral naltrexone challenge, so giving a smaller dose of the medication of the antagonist, and that causes opioid withdrawal, that means that there's still opioids on those receptors, and we could make symptoms much worse if we give them the extended release naltrexone. They have a positive opioid screen that also suggests that opioids are in the system. And then also, taking a good allergy history can be helpful as well for providers and audience. So once we sort of go through that checklist and make sure that there aren't any absolute contraindications to using naltrexone, we really need to have an open and honest discussion with our clients about the different level of efficacy of naltrexone compared to buprenorphine and methadone. And this was from a study just last year. The buprenorphine and methadone is sort of that tannish brown line. The naltrexone is the sort of silvery color line. And they look at sort of time to opioid overdose at 3 months and acute care use. So having to come back to the hospital often with complications stemming from opioid use disorder. And they saw that there was this significant difference. So buprenorphine and methadone were superior to naltrexone in terms of reducing the risk of opioid overdose at that 3-month mark. And you see that those curves separate even further out as we get further and further in time from last use. Similar with acute care use at 3 months. We see that there's more benefit to buprenorphine and methadone compared to naltrexone for these clients. And when we look at real world retention, so keeping people in care so that we can address, maybe other serious mental health, other physical health issues, make sure that they're building back their social circle in a positive way, making sure that they're achieving their employment goals. Retention is huge, and in the real world, we see that there is a difference in those patients who are maintained on methadone or buprenorphine compared to naltrexone, with much lower rates of retention on extended release naltrexone. So once we have that really open and honest discussion about these have different levels of efficacy because they work in a different way, and clients are understanding of that and still want to move forward with getting extended release naltrexone, we really have to do a lot to make sure that they get back into care when they're due for their subsequent shots. We have to educate, talking through concerns about return to use and how they're more susceptible to an overdose because they've lost that tolerance. We do motivational interviewing, making sure that they have intrinsic motivation for continuing on therapy. And it's not just sort of an outside motivator that's driving them to be on extended release naltrexone. Contingency management is the idea that people respond to incentives, right? And so if we can incentivize staying in care, people tend to do better. It isn't a huge effect in some of the studies that we've looked at, but enough where that could be another injection that they get if they are staying in care. And so that can make a huge difference in terms of reducing their overdose risk. And then we want to make sure that there's benefit in them staying in care, in that we can treat their mental and physical health issues as well. So collaborating, if those are not things that organizations that you work with offer, making sure that folks are referred to physicians and other community centers that can provide support for mental and physical health issues. Okay. So that's our overview. Let's talk through some of the questions that you had after listening to our session last week. Okay, The first one's pretty straightforward. Someone asked, who can prescribe extended release naltrexone? Do you need a DEAX waiver? So you do not need a DEAX waiver. If you are a physician, nurse practitioner, PA, extended release naltrexone is something that you can prescribe. You can prescribe it in an inpatient setting. You can use it in an outpatient setting. Really, the bigger barrier is making sure that there is a system in place for the safe storage of this medication, and that you're adequately trained to provide the actual injection, because this is an injection medication. So if people want more details about those processes or what we do at our First Bridge Clinic or on our inpatient side at UK, I'm happy to go into those details. But the short version is that you do not need an additional waiver to prescribe extended release naltrexone. The other argument I would make is get your waiver, right? Because if somebody comes to you initially saying, I would like extended release naltrexone, and you talk through the pros and cons, and they say, actually, buprenorphine seems like a better fit for me, being able to offer them more than one option for the treatment of their opioid use disorder can make a huge difference. Is naltrexone a good option for someone with alcohol use disorder and opioid use disorder? We know that the FDA has approved extended release naltrexone for both the use of alcohol and opioid use disorder. And so is this really the first option for someone with both disorders? So I'm going to pull in a few of the studies and data that I presented in our alcohol and opioid use disorder lecture to try to answer. So these numbers are a little bit on the small side, but let me just sort of orient you here. When we look at people who have opioid use disorder and also use alcohol, this study is showing that when you have somebody who is taking buprenorphine, they and have an alcohol use disorder, they're less likely to get that medication. Same thing with methadone as well. So having an additional substance use disorder, and that's in this particular study of veterans, alcohol was the most common of those substance use disorders, predicted that they were less likely to receive what we know is highly effective medication for opioid use disorder, either buprenorphine or methadone. And I think gets to the discomfort that many clinicians have about managing multiple substance use disorders. Often they don't have adequate training, or they didn't have a ton of experience or guidance or mentoring to help deal with the challenges that come up when somebody is using both alcohol and opioid use disorder. So they get hesitant around prescribing these medications. I think there's also the concern, and a very real concern, that when using an opioid, of which buprenorphine and methadone are both opioids, and alcohol together, you have a higher risk of potential side effects. So difficulty breathing, sedation, those sort of things, and even an unintentional overdose. And so there's hesitancy to prescribe that, which I think we can think of as a little bit dissonant, because these medications we know are safer than the illicit drug supply that's out there in terms of overdose risk. The other thing that we run into with alcohol use is that it can impact buprenorphine dosing. When somebody has significant impairment of the liver function, that means that buprenorphine is going to be cleared more slowly than if somebody didn't have liver issues. That can lead to more sedation, more side effects, nausea, constipation, those sort of things. And as the liver function gets even worse, we have to use really small doses of buprenorphine that may not adequately treat cravings for folks to use that safely. And so for patients using alcohol and it causing damage to the liver, things can get a little bit complicated. when patients are offered appropriate treatment for their opioid use disorder, it actually tends to lower the risk of having alcohol-related events. So that can be hospital or emergency room stays, that can be accidents, that can be liver disease development. When folks are on medications like buprenorphine, naltrexone. So this study was not meant to compare those different medications for folks with both alcohol and opioid use disorder, only to say, if we know that all these alcohol-related events happened, if we look back and we see if they received buprenorphine or they received methadone, did that change their risk? What you see here listed as the odds ratio, over time of developing an alcohol-related event. So you actually see buprenorphine and methadone, those odds ratios, they're under 1. Okay, so that's a good thing. So buprenorphine, methadone, around a half to even 60+% reduction in the risk of alcohol events when they're on appropriate medications for opioid use disorder. Again, this was not a study to look at whether there was a difference between those two and naltrexone. We have two really workhorses of alcohol use disorder treatment, acamprosate and naltrexone. Acamprosate, one drawback that some folks have is it's 3 times a day or TID dosing. And that can be a lot to remember to take a medication a day. The way that I'll often counsel patients is, those are 3 times a day where you are taking a medication to help with your cravings, but it's a 3 times a day where you can check in on where those cravings are at and say to yourself, I'm taking this medication, but what other things do I need to be doing right now to help reduce my risk of drinking today? And that might be reaching out to a peer or a counselor, going to a meeting, but it's a nice little reminder, if they use it as such, to make sure that they're tapping into all those other resources. It is associated with a decreased risk of return to drinking, no reduction in likelihood of binge drinking in the small studies that were conducted with it, and a common side effect is loose stools. Naltrexone, we've talked about sort of the difficulty initiating folks on naltrexone who have opioid dependence. It's available in that IM formulation. And again, that's the formulation that we want to be using rather than the oral formulation in patients with opioid disorder, because we know that the oral formulation is inferior to the IM formulation when it comes to important opioid uses. And it similarly has a good impact on decreasing the risk of returning to drinking. Nausea and abdominal discomfort are the main side effects there. So when I think about patients with opioid use disorder and alcohol use, I want to first understand, does their alcohol use actually meet criteria for an alcohol use disorder, right? Because oftentimes it might not. And if they don't have an alcohol use disorder, it may be that the most important thing is controlling their opioid use disorder. So that's step number 1. Step number 2, if we feel like they have both an opioid use disorder and an alcohol use disorder, I still favor trying to get folks on buprenorphine or methadone because of the difference in retention and care and overdose risk reduction with those medications compared to naltrexone. And as I showed a few slides ago, those medications still help significantly to reduce alcohol-related events in patients with opioid use disorder and alcohol use. What I'll sometimes do, if we're having persistent breakthrough cravings for alcohol use on top of somebody who's on buprenorphine or methadone, is reach for acamprosate, right? Because we can use those medications together. Whereas, we would have to make that decision up front about starting somebody on naltrexone. I feel much more comfortable getting them on buprenorphine or methadone, and then adding on the camprosate if needed, rather than just trying to make things work with a naltrexone. I think the other thing to think about is why are they drinking, right? Are they drinking because of untreated pain, which is something that naltrexone cannot help with? Are they drinking because of untreated mood disorders, which is something that naltrexone cannot help with, right? Buprenorphine or methadone can't help with either. But we need to be screening those folks for mood symptoms, sleep issues, pain issues that might be really motivating them to continue to drink. Just summarizing my answer, I still lean on buprenorphine and methadone as first-line treatment for opioid use disorder in somebody with alcohol use. They have a true alcohol use disorder, I will reach for a camprosate. If their goals are aligning with using naltrexone for both opioid and alcohol use disorder, then we'll talk through the risks and benefits. I don't see huge drawbacks to that, but we have to be able to be open and honest about how it is a different medication with different levels of efficacy compared to buprenorphine and methadone. Why do we have more data for buprenorphine and methadone compared to naltrexone? But this is a little bit complicated. One is that research with extended-release naltrexone can be difficult. When looking through some of the research for this topic and the session last week, I had to do some sifting through, what was sponsored by industry, the makers of naltrexone, and what was really. Buprenorphine and methadone have been around longer, so decades longer than extended-release naltrexone. So we have more of those longitudinal studies tracking patients and seeing how they do in the long run. Reporting requirements and regulations can be a little bit different in the settings that naltrexone is sometimes given. So if we think about some of our residential addiction treatment programs, if we think about some of our corrections facilities, sometimes it can be difficult to get data on patients who are residing there and be able to interpret them. Mechanism of action, right? So because there's no withdrawal to naltrexone, some patients will stop it and not tell their physicians. And so there's this loss to follow-up issue with the naltrexone that becomes more difficult. So lots of different reasons why we don't have sort of the same level of evidence with naltrexone versus buprenorphine and methadone. But the important point is that we have, I think, enough evidence to say that these are different drugs, and we have to have a different approach with extended-release naltrexone compared to buprenorphine or methadone. This was a study by Wally and colleagues out of Boston a couple years back, I think. And the thing I wanted to point out is that it was a very large data set. So you see on the left side there, in the early parts of the 2010s, they had between 400,000 and 1.7 million patients in these data sets. And when you look at sort of that's the number of people times the number of months that they were being followed. But that's still pretty high number. The injectable naltrexone, in terms of the percent total of this study, was around 1%. The oral naltrexone, 2%. Buprenorphine in the 80+%, right? So in terms of these data, we just had more people that we could track and follow who are on buprenorphine compared to extended-release naltrexone. Okay, I really like this question, and I'm so glad that we brought it up. And I think this is a really good time to open it up to the rest of you guys, because I've been talking for a while. So how do you identify good candidates for naltrexone? I'm going to go ahead and put some notes in here, but I'd love to hear what other folks think. Who do you guys think makes a good candidate for extended-release naltrexone?
Highly motivated clients or patients?
Highly motivated. Can you expand on that a little bit more? So
I would say the ones that are, they're really ready to be done.
Really ready to be done.
Yeah.
Okay, what else, guys?
Ones that forget to take their medication daily. So they,
Yeah, so like medication adherence challenges, right? I think it's important to highlight are those challenges because of something that we as a system, a healthcare system, are failing the patient on, right? So able to get them transportation, or is it more of a personal issue where actually it's really hard for them to remember to take something every day?
right, both, yeah.
Both sort of personal and structural. What else?
To kind of go along with that, I think someone who's like really busy, maybe their work schedule, where they have kids, that just coming in daily for medication or making that work isn't feasible.
Yeah, especially early in treatment, right? So, our current state regulations around buprenorphine require pretty much around a week or so follow-ups for the first month of treatment. And that can be really challenging for some patients who, their opioid use has interrupted their life, certainly, but they're still working full-time, right? Or they still have childcare responsibilities at basically a full-time schedule, and it's difficult to arrange for coverage for even an hour-long visit. And we all know that it's never just an hour sometimes for those visits. What else? I would point out here that like prior success with it, right? And that's a little bit of a double-edged sword, right? Because we definitely need to dive in and understand, what caused a slip or a return to use after being on extended release naltrexone. But if they were doing well on it, then who am I to discount that hard work that they're putting in to get into long-term recovery? And I need to make sure I'm understanding what other factors what were helpful to them during that time of sobriety. But prior success, certainly one. Do you guys ever see clients where like it seems like this is the only option for them?
I think avoiding stigma could be an issue as well.
Yeah. So talk to me a little bit more about that, Mr. Maynard. Like stigma towards other medications for opioid use disorder?
Not having to present to clinic as often. Issues like that where they can be exposed potentially to family members and or family and community members, unfortunately.
Yeah, so I'm hearing sort of family, like the recovery community, right? And also like community at large.
Right.
Are all sources of stigma or pressure when it comes to what medication is perceived as best option for somebody. John brings up a good point of, would it show up in a drug screen? So it just depends on the drug screen, John. So, sometimes most of the standard ELISA ones will not look for naltrexone. It can be picked up on some of the liquid or gas chromatography studies. But yeah, like if, work requirements around what they can be on. So I think these are a lot of just real world examples of some of the reasons that folks choose extended release naltrexone. But I love that you guys bring up the reality that many times this is something that clients struggle with. They're not 100% certain that it is the right medication for them. And so part of those initial visits are going to be really focused on building that motivation to say, okay, I need to be able to come in and get this next shot. Even if I'm struggling a little bit, I need to make sure that I feel comfortable going back and having a conversation about those struggles. So those are all great points. Okay, but I do want to say this, right? And I think this is really critically important. Some patients who are on extended release naltrexone are on extended release naltrexone because of coercion. Okay. I want to be clear, right? This is an effective medication, and it's effective medication for some of the groups that you pointed out, but no medication, buprenorphine, methadone, naltrexone, is universally accepted or applicable to any one person, okay? When you combine one form of treatment, so let's say somebody really wants to be on buprenorphine, and another form of treatment, let's say, required counseling or groups that maybe they felt really stigmatized in before, that can be perceived as coercive. When we threaten more treatment, right, without aligning with the patient's goals, right, if we're able to get you to a residential program, I think some of that chaos in your life might settle down a little bit, and you're going to be able to focus on what your recovery looks like. Versus, you have to go to residential programs because you are not coming in adequately, right? Or giving the right urine results. That threat is still a threat, and we have to recognize it as such. Individuals involved in criminal courts or family courts, we really need to be attentive to coercive practices there. And when we're withholding evidence-based treatment for other medical issues, pain issues, valve replacements for endocarditis, based on what type of opioid use disorder treatment somebody chooses, that's coercion as well, right? So I recognize that I have coerced patients before in small and not so small ways in thinking about treatment. And I really try to fight against that on a daily basis and try to understand where they're coming from. And so if we're not doing that, then I think we're missing out on reaching a huge group of our population that could use help and assistance. So those are some of the, oh, we got another question. How long should a patient stay on naltrexone? So this is a study that actually showed this, right? So they looked at patients receiving buprenorphine and injectable naltrexone. So the sublingual buprenorphine, sort of our most common form of buprenorphine, is the dotted line at the top, near the top of the graph. The injectable naltrexone is the gray line. And what is this showing? So it's time to discontinuation, so how long they stay in treatment before they stop the medication, and the proportion who have an active prescription, who are still getting the medication, right? So a good marker here is to just look at 30 days, right? So let's look at, at 30 days, if we were to draw a line, and I can do this actually. Let's draw a line. Draw a line. Okay, can everyone see that? Okay, so at 30 days, let's see where our dotted line is with Suboxone. So our dotted line is right up here around that 80% mark. And then our sort of hard silver gray line is around that like 50% mark with injectable naltrexone. And then let's draw another line. Let's draw a line at 6 months. That's a good time, right? So 6 months, 180 days. I think I'm doing that math right. So 6 months, we see that buprenorphine, is around sort of that 40% mark, and naltrexone we're around less than 20%, nearing almost 10%. So the point being here that there is this signal, and we saw this before in some of our efficacy data, that people are dropping out of injectable naltrexone earlier than folks who are on buprenorphine. And that those dropout rates are pretty high even for that first month or so after the initial injection. And we know that that's a really high risk period for people who are stopping extended release naltrexone because they've lost their opioid tolerance. So the second question that we ask when thinking about, how long somebody should be on naltrexone is what do we know if there's predictors that somebody is going to fall out of care, that they're going to stop getting injections? And there's definitely a few. So this has been looked at. This was a study from a few years ago, and looked at patients on all different types of medication for opioid use disorder, so both buprenorphine and naltrexone. But it also looked at other factors. So the age that they started the medication, whether they were male or female, other substances that they were using, if they were ever seen in a detox facility, what type of provider they were seeing when they started, and the place that they started the medication. So just a couple key points here. So when looking at people who were started on medication when they were younger than 30, or those who were 30 or older, the younger population was at slightly higher risk, so about 25% more were at risk for stopping their medication, right? So first lesson is somebody who's on the younger side, we have to double our efforts to try to understand what their motivations are for continuing treatment and make sure that treatment is aligning with those motivations. There wasn't a difference male versus female. There was more of a challenge in keeping people in treatment as you had more substances in the picture. So alcohol, amphetamines, cannabis, cocaine, hallucinogens, sedatives. So when we're seeing patients who are on extended release naltrexone, we want to keep on asking about, are they using other substances and why they're using those, right? Just like with alcohol, are they using it for pain? Are they using it to try to get to sleep? Are they using it for mood issues? If they'd seen it in a detox facility, there was a slight signal towards maybe less of a risk of them discontinuing. Similarly, note maybe a little bit of a reduction in risk of discontinuing if they were seen in a psychiatric setting. But those are sort of the main takeaways. The younger population is at greater risk, and people who are using other substances are at greater risk for stopping. And so, to answer this question, I think it has to be patient-centered, because we need to be tapping in from that first visit to what is their motivation to be on naltrexone, number one. We have to educate folks about the significant risks that come in that period right after discontinuation in terms of return to use and overdose. We have to pay special attention to our younger population and our patients who are using other substances because they're at greater risk for stopping their medication as well. So we need to treat those other substance use disorders if we can confirm that they have them. Any other questions before we jump into the case studies? Those were really great ones. Thanks for those.
Is there any data that supports the reasons for use being more troublesome, whether it be for physical pain or whether it be for recreation? Is one or the other proven to be of greater risk?
So that's a good question. I think the main challenge right now is what people have been using in terms of opioids is drastically different now compared to a decade or even 5 years ago, with increasing levels of fentanyl in even what people think is oxycodone or Percocet tablets or that sort of thing. There is just that higher risk of overdose and death with exposure to those. And so while some of the prior studies try to answer that question of, hey, is it prescription opioid use that is more of a overdose risk, or is it non-prescribed substances, non-prescribed opioids that are more of a risk? Really, we're in a different world at this point. And patients who meet criteria for opioid use disorder, we need to be aggressive about making sure that they get access to evidence-based treatment. So sorry if that's a little bit of a non-answer, but the reality is understanding their story is important, but really we need to lower their risk by getting them onto medication and other evidence-based treatments. Let's go ahead and jump into some case studies. So this is the first case study. This is a 25-year-old guy presenting for hospital follow-up after being admitted for endocarditis, so infection of the heart valves related to IV opioid use. He's been using opioids since his early 20s and IV use over the last 2 years, mostly opioid pain pills, but has started using heroin and or fentanyl as well. He's also used some other substances, cocaine, meth, and benzos. His drug screen is positive for morphine and fentanyl, and he went through some medically managed withdrawal in the hospital, but had severe cravings and resumed daily injection of heroin when he got out of the hospital. He's attended a few 12-step meetings, which he thinks are helpful, and works at a local restaurant, lives with his girlfriend who does not use drugs, has a history of legal charges, and some recent health issues have frightened him. Also known a couple people in the last year die from a fentanyl overdose, and says that he wants to quit, but has not had success yet. So my first question to you all is, what do you guys think if he says, I'm interested in extended release naltrexone? What are some things that you feel like extended release naltrexone would be a good fit for him? And what things make you a little bit concerned about extended release naltrexone for him? And you can put in the chat or you can unmute. I'll monitor both.
What would make me concerned would be the daily use of IV.
Okay.
Will he be able to go 7 days in that withdrawal symptom, stage to be able to get on the extended release naltrexone? That would be my concern. That would be pretty risky.
Right. So if he's coming in and he's wanting to start treatment now, and maybe isn't aware that it takes having to get him through withdrawal again, and he can't really start naltrexone for 7 to 10 days, how does that change his thinking? So I love that we're already thinking about what that initiation process would look like. Other thoughts?
The severe cravings that he had through the medically managed withdrawal, research, right, isn't there to say that it is super effective with the cravings. Is that accurate?
It's not that it isn't effective at reducing cravings for opioids, it's that it works in a different way, right? So methadone and buprenorphine impact cravings by directly activating the opioid receptor. Naltrexone is going to impact cravings by slowly extinguishing the sort of dopamine response that comes when somebody is injecting or using opioids in a different form. So the first time that they use an opioid, and don't get an effect from that because naltrexone is on board, the next time they start thinking about using, they know that the medication is in their system, that they're not going to get that positive impact of use. And so they're less likely to reach for that, right? So it reduces cravings, but in that sort of slightly more roundabout way. But I think you point out importantly, right, that even while he was in the hospital, he was starting to have cravings. Even while he was going through that managed withdrawal period, he was starting to have cravings. And it wasn't clear exactly whether he was ready to stop use at that point. He seems pretty motivated right now. And it's not clear sort of what was offered to him during the hospital during that time. But I'm certainly worried about him navigating another period of protracted withdrawal symptoms.
Also, wouldn't the fact that he's willing to use the heroin and fentanyl as opposed to opioid pain medications. And if he's not getting the result that he's used to getting from those, he might accidentally overdo the fentanyl or heroin, not knowing exactly what's in it, trying to get an effect from it.
So I think you bring up a really good point, right? For, what does the heroin or fentanyl use? It seems like it's more recent. What does that represent? For many clients, what that represents is tolerance to the opioids that they're using before switching over to heroin or fentanyl. For some, it's representing increased costs to using those pills, right? Because it is cheaper and more easily to access heroin or fentanyl in many situations around our state. So I think you're right to say something has changed in the last year or so as he started to use heroin and fentanyl. Is it cost that's driving things? Is it the fact that he has had more tolerance, needing more to get the same effect? Is it that he's experiencing more withdrawal symptoms in between use and so feels that IV is going to relieve those withdrawal symptoms quicker? Really trying to understand his perspective is going to help us figure out what challenges he might face as he attempts getting into long-term recovery. Any positives that folks see as for extended release naltrexone in this gentleman? I think this is important to try to pin these down as well.
He has a job
Yeah.
and a
So,
girlfriend who doesn't use.
right. So exploring with him, what would be his work's response if they knew that he was on this medication, right? Or what would be his girlfriend's response if she knew that he was on the naltrexone versus methadone or buprenorphine. So exploring maybe some of those perspectives or ideas about the medication that his work or his social supports have.
He's also exploring actual recovery as far as going to 12-step meetings, thinking
Yeah.
that they may be helpful. So that might be once he gets a little further into that.
Yeah, and we certainly know that from some qualitative studies that in many, I'm not going to say most, but in many 12-step meetings, naltrexone is looked on differently and with less stigma compared to buprenorphine or methadone. I don't think that should be the primary driver of somebody choosing which medication is right for them. But at the same time, if we just sort of cover our ears and eyes and say that that's not happening, that's not helping folks either, right? I think the one other thing I would point out here is these legal charges, right? So if I am starting him on a medication, buprenorphine or methadone, where the reason that it is effective and the reason that it helps protect from an overdose is that we develop opioid dependence on those medications, what I'm committing him to is when those are potentially stopped or interrupted, he will go into withdrawal. Right. And so for somebody where I don't have a great understanding of the legal issues that are going on, we have to explore that before we're committing together as a team to say, we are going to give you opioid dependence to protect you from an overdose, to reduce your cravings, because I don't want you to have to navigate opioid withdrawal through the prison or a jail system. If medication for opioid use disorder is offered in a jail, that's fantastic, but I don't think it's at a level right now where we can just ignore the fact that this guy could be picked up and his care interrupted as a result. And so having him on a medication that doesn't involve withdrawal symptoms may be helpful in this setting as well. Does that make sense? Any questions about this case? Awesome. Let's go on to the next. Okay, so this is sort of like on the other side of things. 45-year-old male has recently been released from jail, currently looking for a job, doesn't have his own transportation. He has overdosed in the past and is worried about return to use. He hasn't used opioids in the last 6 months while incarcerated. So what are some things that are potential benefit to him when thinking about starting extended release naltrexone? What are some reasons that he would be a good candidate?
He's already been off of the opiates for 6 months. So he would
Yep.
definitely clear that time period.
Absolutely. Now, opioids can be obtained in jails. And so we would still want to do, a urine drug screen to confirm that there's no opioids in his systems. But yes, the fact that he has already navigated withdrawal, he does not have any opioid tolerance, certainly makes initiation of extended release naltrexone easier for us here. What else?
He doesn't have transportation, so getting to daily, weekly sessions,
Yeah.
meetings would be typical.
Great point, right? He doesn't have his own transportation. And I know we're doing a lot of work in trying to limit that as a barrier to getting medications for opioid use disorder that are aligning with patient goals. But that's sort of staring us in the face right now. How is he going to get to a clinic?
Also, if he's looking for a job, he's most likely going to have to do some drug screens and probably also report to probation or a parole officer or someone. So
Good.
they might look more favorably on the naltrexone.
Yeah, so I think it is really important to have that open and honest conversation about, hey, what conversations have you had with your parole officer about medications for opioid use disorder? Have they shared any concerns at all with any of these particular medications that we offer and that we know can be effective in reducing cravings and return to use? So exploring with that is certainly an important first step here. If we're thinking about, let's say he's on board with extended release naltrexone, he wants to start it. What sort of things do we need to do before we give him the shot?
You need to do the screening just in case he did take something in between getting out of jail and going home.
Love it, right? So we need to do the screening. Sometimes folks don't recognize certain opioids as opioids. So like tramadol is a good example there, right? Like I'm not on an opioid, but it has activity at the opioid receptor and would send them into withdrawal if they are used to taking sort of the same dose of that. So getting a urine drug screen, getting a CASPER or a report of what's been prescribed to him in terms of controlled substances in the last year. Are there other labs or things that we would want to do?
Definitely would want to do a medical screening to check on his liver
Good.
function and
Yeah. And again, the clinician, the provider who's seen this individual would need to order some blood tests. And so sometimes it's just important to give our clients a heads up that before starting this medication, there will be some blood work involved, right? Many folks with prior injection use might have some issues with getting blood draws. And so we want to be able to talk them through that and make sure that they feel comfortable and safe getting that done as well. But we'll need to check the liver function. Often we'll check, we'll screen them for HIV and Hep C and other diseases that can be transmitted via injection if that's part of their practice. And then, what other things do we want to make sure that we're giving the client before they leave that office that day?
I think providing education on overdose. He had a history of an overdose.
Yeah, and Kenzie, what sort of things could we do to make sure that they're leaving with the right information, I guess?
Make sure that he does have a supply of Narcan.
Yeah, so make sure that he has a supply of Narcan, make sure he knows how to use it. we don't know from the stem whether there was prior injection behavior, right? But we would want to explore that and make sure that they had access to a syringe exchange program and a safer sort of supplies for using if there is a return to use. So all those things I think are really, really critical, even for somebody who's highly motivated, is willing to get the shot, because that might look very, very different a month from now. And if they don't come in for that shot, they're at that elevated risk for overdose. So I'm so glad you brought that up. So I think this is a really good case of, somebody who is a potential good candidate. And we talked through sort of the essential steps, getting urine drug screen, getting some basic blood work, reviewing harm reduction tools, skills, and education with the client that anyone should get, regardless of whether they get the extended release naltrexone shot. And then last case here. So a client through the syringe service program approaches you asking about medications for opioid use disorder and self-help groups. They are currently using heroin 2 to 3 times a week. They have tried to stop using in the past, but couldn't handle the withdrawal symptoms. Due to a recent overdose of a friend, they are highly motivated to stop their use. Okay, so let's think first about our checklist. What are some things that this person would need to navigate before starting extended release naltrexone?
Again, the withdrawal.
Yeah. So what are their options for managing that, right? Let's say they're really high motivated. As they said, they just lost this friend. They want to get on to extended release naltrexone. What options do they have for getting through that withdrawal? I see in the chat, Kenita mentions comfort medication. So yeah, medications that are targeting symptoms, right? If not the opioid receptor. So let's think through our opioid withdrawal, right? There's a lot of like pain involved with that. So pain in the joints and the muscles. So ibuprofen would be, or another NSAID would be something that could help alleviate some of those symptoms. They might have a lot of nausea. So nausea medications, ondansetron or other medications could be helpful during that time. Anxiety, tremulousness, feeling on edge, difficulty sleeping. That's something that clonidine could potentially be helpful for. They need to make sure that they're keeping up with their hydration though, because that can drop their blood pressure. Diarrhea, right? So using anti-diarrheal medications to help them get through that as well. And what should we tell if they're trying to manage that at home? What should we tell patients in terms of how long to expect symptoms or when symptoms might start getting better?
It's been my experience in working in detox that around a week you should be pretty well clear of most of those symptoms, especially with the help of comfort medications. Generally, as just came up in the chat, around 5 days or so, people start to feel much better. Not to be completely clear necessarily, but feeling much better.
So I agree with you. Typically we'll see symptoms peak within that 48 to 72-hour period, that they'll begin sort of subsiding after that. But it can be a slow process, and there can be persistent symptoms, sleep issues, anxiety, muscle aches, fatigue, those sort of things that last even past that week mark. So the key takeaway I would say is this is not a put them on autopilot situation, right? This is not here, I'm prescribing these medications, we'll see you back in a week. You need to understand what their response is to those medications, because if there's an inadequate response, if they're having persistent symptoms or worsening symptoms despite those medications, they're at extremely high risk of returning back to use, right? So absolutely, 5 to 7 day script, totally appropriate, but we need to be calling them that next day and seeing how they're doing, right? Or the day after that, right? Until we start seeing those symptoms subside, checking in, making sure that there's a game plan in place if symptoms are worsening. And that can include coming into the emergency room. That can include going to a dedicated medical withdrawal facility. So those are things that we absolutely need to be doing. We can't just sort of put them on autopilot and say, see you in a week, okay? So absolutely. So let's say they're able to get through those withdrawal symptoms and they come back in a week. What are we going to do with them before proceeding with the extended release naltrexone injection?
Drug screen and blood work.
Love it, right? And we can probably do that sort of that first appointment that they're establishing, the blood work, but we need to repeat that drug screen, right? To make sure that we aren't seeing any opioids still in their system. If we have any concerns, we could potentially do that naltrexone challenge with them. But remember, as we talked about last week, that often involves, unless you have the naltrexone on site, them going to the pharmacy, picking up the medication, having to come back. And if there's issues with transportation, that could be a huge barrier to moving forward. So, okay, let's say drug screen looks great. They tolerate sort of the oral naltrexone challenge of one of the 25 milligram oral tablets. They do great. No withdrawal symptoms after about 40 to 45 minutes, and they're ready for their shot. We went through a video last week, so if you guys want to see sort of how the shots are performed, you can look at the video from last week. But before they leave that office after their shot, what are some things that we want to discuss with them?
Access to I've drawn a blank on the drug, Narcan. And
Yeah, love
Narcan
it.
education. And
Absolutely.
backing up just a little bit,
Sure.
the client in this case was asking for self-help groups. So I don't think we can diminish the importance of connecting them with other folks that can support them through that withdrawal. Well,
absolutely, right. And continue to motivate them to come back in and get subsequent injections. But I love the first instinct of let's make sure that we're keeping them as safe as possible and make sure they have naloxone and other harm reduction education or materials if needed. But I love the point about the other mutual help organizations. So that could be a potential source of support. When do you want to check in with this person? Is this somebody that, let's schedule them for their month follow-up and hope they come in, or is this somebody that you're going to want to touch base with on the earlier side? Weekly. Thanks, Natalie. I think that's a really great point, right? It doesn't have to be much. It can be a phone check-in. It can be in-person check-in, but making sure that they aren't dealing with any significant side effects of the medication. So it can cause some nausea. It can cause a little bit of stomach pain. So making sure that they're aware of that. It can cause some sleep issues, some mood issues, making sure that we're being aggressive in treating those symptoms as well. And sometimes it can be a little bit difficult to tease out how much is sort of subacute withdrawal coming off the opioids versus the naltrexone itself, but still useful to check in. John, good point. Does naltrexone have the counseling requirement that methadone and buprenorphine have? And not within our state regulations, but I think that for those who have, and it's rare to find somebody with an opioid use disorder who doesn't have other significant mood issues or sleep issues that counseling can benefit. I think trying to get them in with a counselor, and that increases the touch points that you're having with them as well, to make sure that they're doing okay and motivating them to come back for subsequent injections. Well, I'll just end with this note that, as I said before, no one drug or medication is applicable to all folks or acceptable to all folks. This is a critical medication in our arsenal to address opioid use disorder. And certainly for those who it aligns best with their goals and wishes. We want to make sure that we are lowering every possible barrier to get them into remission of their opioid use disorder. But as I hope last week's session and this week's session showed, this is hard. And so making sure that at minimum folks feel accepted, they feel that they have options when it comes to treatment, and that we, regardless of what they choose, are providing them with the best possible education, harm reduction resources, and just support and love. We're going to be in a better place. So thank you for your attention and time, and I'll take any other questions at this point.